Great. Hi, welcome back from break, everyone. Or if you're joining us for the first time, welcome all together. I'm Dr. Rob McKenna, the Acting Deputy Regional Administrator in the Region 3 Office of the Health Resources and Services Administration. I'm excited to welcome you to this session, Disruptions in Health Professions Education, in which we're about to have some great conversation about health professions education and training. In fact, that conversation already started if you were in the keynote chat just a little while ago. We already got started. So I'm being very sincere here when I say I'm excited. I tell everyone that out of literally hundreds of conferences, this is by far at the very top of my list in terms of excellence in my opinion. People are getting tired of hearing that from me, but it's true. And I know you'll think so too at its conclusion. As for the format of this conversation, we'll start with some short presentations from each of the three panelists, and then they will have an opportunity to respond to some prepared discussion questions for the remainder of those sessions. As that dialogue occurs, please do feel free to contribute to the conversation through the Q&A function on Event Mobi. And if we have time near the end, we'll open it up for those questions or further comments and questions. There's lots to talk about, so let's just jump in. We are really fortunate to have the panel here that we do. Lots of expertise, some of which you can read about more fully in their bios, should you choose to do that. It is my honor to introduce them, and they would be Dr. Sandra Davidson, Dean and Professor of Nursing at the University of Calgary, Dr. Shamli Abdel-Fattah, an Associate Professor of Pharmacy Practice and the Director of Healthcare Innovations at the Appalachian College of Pharmacy, and Dr. Lisa Howley, Senior Director of Strategic Initiatives and Partnerships of the Association of American Medical Colleges. Welcome panelists, and again, welcome everyone. And Dr. Sandra, I believe you'll get us started. Well, slides, please.
All right, thanks so much, Rob. My pleasure to kick things off. I agree, Dan set us up just beautifully with his keynote this morning, but I'm going to pick up a little bit and talk about some more details. So next slide, please. So the way that I think about healthcare education and higher education in a lot of instances in general is a little bit like the Titanic that never sank. And if you what I mean by that is, when the Titanic struck the iceberg in April 1912, it represented the highest achievement of engineering and design at the time. And in many ways, our education system is much like the Titanic. It was really state of the art for the beginning of the 20th century. However, the education system, as we know, did not meet with an icy adversary. Instead, we've lovingly cared for, maintained, and kept in working order for more than 100 years our post-secondary education system and healthcare professional education as well. Of course, every decade or so, we change the features, new coat of paint, the latest fashion in education, but basically at the heart and underlying all the embellishments, it really is a large steam-powered boat and steam-powered engine, or in the educational world, linear, content-laden kind of behaviorist education that we are largely stuck with. And when you think about health sciences innovation, I doubt that the first things that come to mind are innovative or future focused. So why has it been unchanged for so many years? Well, there's a lot of organizational, political, philosophical reasons. And it's really, become this undisruptible thing. It's one of the behemoths of the 20th century that education has remained the same. And, a lot of people are claiming, higher education is broken, and that's kind of a narrative we hear. But what I would say is it's not broken. In fact, it functions very well. The problem is that it's a system that was for an outdated time. It's a throwback to the Industrial Revolution, and the system is just obsolete. So if you think about it, in the slide here talks about, instead of looking at a well-maintained ocean vintage liner, some of our super ships represent and future focus where we want to take education in the future as well. So we need to think about a different way of moving forward in our 21st century healthcare realities and adopt a a different way, metaphors of a different way to travel that represent better where we want to go. So next slide. So finally, I think with COVID, our vintage ocean liner has hit the iceberg or the virus. And so really, we're looking at things changed overnight. The people that were, teaching happily face to face had to go online overnight. That to me is striking the iceberg and really disrupting things. There was a rapid move to things like virtual simulation because there had to be. We had students that were doing teleclinicals, and we were questioning things like what actually counts as clinical hours. And, sometimes the clinical definition is that it is face-to-face patient engagement. Well, we had to question that to make room for, telepresence and health assessments that our students were doing and doing great and having wonderful practice, but not face-to-face. So from an accrediting body, what counts as clinical in this post-pandemic world? And generally, rethinking things. Why have we done it this way for so long and not something else? And rather than looking at seat hours, we're moving towards more competency-based education. Next slide. The so what? So the author that I have here, this is really interesting, is a gentleman who has done his whole career, has looked at health sciences and higher education, and a lot of the evidence that's there about best practices and best outcomes for teaching and learning. And after a whole a whole career of looking at this and diving into every study that was done since 1970. So what did we learn? And I think this is really important to think about evidence-based practice in healthcare education, not just practice. So if we go to the next slide. So these are some of the things that the salient points of that whole body of literature that we're able to look at as and what we're looking at is these are the things that have an impact on student outcome and better student learning. So things like involving encounters with challenging ideas or people. So having students' mental models be disrupted creates space for new learning. So that is a throwback to a lot of what Dan said this morning about innovation and doing things differently. Requiring, can you slide a little? Oops, sorry. I'm getting notes from the side here. And encouraging real live active learning. So a lot of movement around work integrated learning, those kinds of things. Learning that involves other people, big surprise. Students learn better when they're actively engaged with others. And inviting or promoting reflection. So I think any of the healthcare educators are not surprised by this. We've probably lived this and seen this play out in our classrooms, virtual or whatever, but just as a frame that evidence-based innovation is, we think about technology, we think about, a lot of the contextual things that are happening clinically. When it comes down to learning, these are some of the basis of evidence-based innovation that we can leverage in healthcare. Next slide. So what about technology then? I think one of the things that we need to be aware of is that technology is not a panacea. We're using it more in how we teach and learn necessarily and much to our benefit. But what I would say is at the heart of it, and hearkening back to the last slide, all the technology in the world cannot make up for bad course design or bad andragogy. And in fact, it often makes it worse or more visible. Because you can't hide as easily as you could in a face-to-face class with 200 students in a lecture theater. And again, technology is not a tool. It's only a tool, and it's the users of it that determine the outcome of what we're using it for. So hearkening back to design thinking and user experience. And so, keeping that in mind in terms of teaching technology that we are using. And next slide. One of the other things I wanted to highlight, speaking of disrupting health health professions education. Just recently, before this session, MIT Review came out with the top 10 breakthrough technologies of 2021. So if you look at that list there, and I've highlighted in purple the 3 that are directly related to the pandemic, right? So the messenger RNA vaccine, our whole ability to deliver vaccines quickly, to develop and deploy the vaccines quickly, huge technological breakthrough, digital contract tracing, remote everything are 3 things that have happened really this past year because the pandemic and this disruption has enabled innovation, created new constraints that we've had to react to in a whole different way. And so I would say, as health profession educators, how are we thinking about and educating and leveraging these technologies, or how could we in the future to prepare the workforce that is really going to be interacting with them in their careers ongoing? Next slide. So what you have here, and again, I'm being provocative and kind of not going very deep, but just giving you a preview of coming attractions. The other thing that I think is really important to think about for health professions education post-pandemic and in the technologically rich world that we're in, really thinking about interprofessional practice in a different way. And by this time, I think we're up to at least 4.0 in how we envision this. So, instead of just thinking about interprofessional practice as the trinity of nurses, physicians, pharmacists, and other healthcare providers working together for better patient outcomes, it's time to start engaging a whole cast of other interprofessional disciplines. So I have here, the big data, machine learning, AI scientists, those that are really good at looking at, the one of the disruptions was the TikTok algorithms. So social media researchers, environmentalists, venture capitals, entrepreneurs, and so all of these folks, and veterinarians, again, so looking at things like One Health and the impact that we have as healthcare providers on the world and the environment, and animal health and people health and plant health altogether. And how we think about health differently is one example of it. But as I think Dan was talking this morning about, we have all these algorithms and machine learning pieces and technology that give us as clinicians good information. But the folks that are designing them, unless we pair with them and we have the clinical expertise and the clinical knowledge to really have them create algorithms that clinically make sense. What we're finding in some of my practice is that the machine learning scientists are really good at creating a kick-ass algorithm, but they don't understand clinical significance. So I think when it comes to trusting the data that we're getting, having nurses, pharmacists, physicians that are conversant enough in big data, machine learning, and the principles of it to really integrate into some of those teams that are designing for clinical practice is one way that we get to having more robust, clinically relevant algorithms that clinicians can trust because they were a part of that design process. Next slide. So all that to say, and going back to our big ocean liner, we need to think about different ways that we want to travel into the future, new metaphors and new paradigms of travel, and how we educate our students to become part of that profession, and really the leaders and drivers of innovation, as well as the innovators themselves. There's more than enough roles for everybody to take on. So thinking about, those transportation metaphors, and rather than the ocean liner, what would happen if we thought and talked about nursing education or health professions education from a metaphor of being beamed up or traveling into the future? And Dan and I were having an exchange just recently about nursing has to ramp up our technological and innovation science within our curriculum, or we're really going to run out of road. And what we're going is a place where we don't necessarily need roads. And so that is what I will leave you with in terms of a call to action for how we can reimagine healthcare education as we go forward. Thank you.
And next we'll move on to Dr. Shanley. So Dr. Shanley, if you could unmute your mic, please.
Hello, thank you.
Now we can hear you. There you are.
Thank you for attending. I'm with the College of Pharmacy, and our focus is to bring you the new pharmacist that you can use that will be able to be a part of your interprofessional development. So traditionally, the role of the pharmacist has been behind the counter to fill prescriptions and more or less available for the patient. Our disruptive technology would be to use both of the technology and the clinical training to prepare you a pharmacist who can do the collaboration, virtual innovation with the patient and provider 24/7. All right, the pharmacist is capable of providing a lot of clinical services such as chronic disease management, annual wellness, remote patient monitoring, chronic disease management, medication therapy management, and medication reconciliation, and care coordination. And so the first step we have been focusing on as transforming the pharmacist education and bring you the pharmacist of the future is to train the pharmacist in being able to manage chronic disease condition, being able to collaborate with the provider, will be able to engage with the patient, not just only as needed or once a month, but virtually and remotely 24/7. And that's gonna only be happen if the pharmacists are trained on those chronic disease condition, are leveraging the technology, and are able to utilize those technology efficiently to be able to collaborate. So traditionally, to put a pharmacist inside the clinic, it's going to be cost prohibitive. Now with technology, we can embed a pharmacist in every clinic virtually, remotely, and the cost effective. And that's more or less is our focus on trying to prepare the pharmacist for the next generation. Next slide, please. Yeah, traditionally, the pharmacists have been filling their prescriptions, but also we train the pharmacist to where they meet with the patient and do medication therapy management, because medication adherence is a huge part of the healthcare system cost and outcome improvement. So if the patient takes the medication, they're going to stay out of the hospital. If they're not, their condition gets worse. So we have pharmacists to talk to them first before they see the doctor on have they taken their medication, or they taken the right medication, how to manage and navigate the side effects. And then talking to them about their chronic disease conditions. And instead of sending them home and see them next month, they give them remote patient devices so they can check their blood sugar at home, blood pressure at home, and those data will come up to the cloud through dashboards and portals and decision-making programs. We'll be able to figure out what's going on with that patient 24/7. We don't have to wait for a month for that patient to show up at the clinic to discover that their blood sugar or blood pressure was so high about 3 weeks ago. Next slide, please. Those are some of the devices we have been using or training pharmacists to use: blood glucose meters, scales, blood pressure monitors, and most importantly, too, next slide, please. Most importantly, too, medication adherence. 50% of the patient, they don't take their medication either on time, don't take it at all, or they take the wrong medication. And we have no way of really verifying that. We have so many barriers. Could be a cognitive issue as the patient forget, or it could be just they don't believe the drug works. We fill the prescriptions, we give it to them, we assume they are taking it. There is no way we can know that for sure. So one of the technology we use, we have a device to where send them a reminder, open their medication pills, take their medication, and that is recorded. And also not also helping them adhering with their medication. But the cool thing about it, also medication safety. If the patient scans the wrong bottle, reach out for the wrong bottle and scan it, that device will be, you got the wrong medication. This is not the metformin or the Lasix you are taking, probably scans the next bottle. So it makes sure that the patient takes the right medication and take it on time like it's supposed to. And that's going to be huge. Those information, patient-generated data from the patient, the clinician does not have it, nobody have it, but if we have access to it, this real-time information to tell us whether that patient is actually able to adhere to the medication, take the medication on time. So those are some of the things pharmacists of the future, the training we are giving them, allow them to remotely patient those patients, engage both provider and patient in real time, 24/7, virtually, with even having to set foot in the patient home or the doctor's office. Next slide, please. The other role for the pharmacist also is the technology with the virtual clinics, and you hear those retail virtual clinics popping up everywhere. So some of those things to pharmacists and the pharmacies could be a hub for facilitating telehealth care visit between the patient and the provider. So there's gonna be an added benefit to have a pharmacist engaged with your patient to allow you to connect with those patients anytime. Next slide, please. This one, it could be like, a moonshot idea or some kind of innovative technology that we might not see it happening. But believe me, about 3 or 4 years ago, we have done a pilot drone project with that deliver medication to remote area mission, which in Southwest Virginia. We were lucky to have 3 clinics allowing us to pilot that project. Next slide, please. And we have also the former governor, Terry McAuliffe, there for that event. So this was before the pandemic. We didn't know back then that technology can come in handy for use by pharmacists. Now they can use it to deliver COVID testing. They can also use it to deliver supplies. They can also use it to deliver medication. And I see also they can use it to deliver telehealth and virtual visits. But also I would like to say that training takes a whole lot of time. A case in point, the pharmacists now are at the forefront of giving COVID vaccination and immunization. We start training pharmacists and pharmacy students to immunization back in 2005. So it's about 15 years ago or 16 years ago, we started that. Now we see the fruits of that. So we believe that technology and clinical training will allow the pharmacist to be a useful member of your multidisciplinary team and help the patient or the doctor improve outcome, cut cost. And that's all. Thank you.
And thank you very much. And now we'll move on to Dr. Lisa, please, with the next slide.
Thank you so much. And yes, I'm Lisa Howley. I'm with the Association of American Medical Colleges. And I want to begin by just thanking the planning committee actually for including myself and of course the association in this really important conference and very timely conversation about disruptions in health professions education, and particularly in telehealth. So I am really delighted and honored to be here, and you'll see why. I mean, this isn't particularly timely in just a few moments. So next slide, please. This is just my disclosures. As you can see, I do work full time for the association and hold a faculty appointment at one of our member organizations, UNC School of Medicine. Otherwise, I have no financial relationships or financial disclosures to share. Next slide. So I certainly don't need to tell this audience and the participants out there watching us and who will hopefully be engaging in a conversation in a few minutes about just how much healthcare is changing. This slide is just some examples of the many ways, certainly not all, but some of the examples of the ways that healthcare is changing. I'm an educational psychologist, but I've always applied my work and practice to medicine and health professions education. So over the past 25 years, having watched and being part of a system that has that you heard a little bit about already from Dr. Davidson. I have been one that has been out there and pushing and working towards innovations and bringing innovations into the education of our physicians specifically. And so at my in my current position at the association, my portfolio is looking at curricular innovation. So how do we understand where healthcare is today, where it's going tomorrow, and then how do we better prepare and close the gap between what we're seeing in practice and clinical practice with what we're teaching about in our medical schools, our teaching hospitals, and even in continuing professional education. So I consider myself a gap closer, or that's part of the work that I try to do, my team and I. So next slide. Our work at the association is actually quite broad. I do work in the medical education space, which I put in red here because since that's the topic for our conversation today. But just wanted to make you known or make you aware that we are also focused on a number of other areas in telehealth. My colleagues across the association work on all of these areas very strategically. And so again, I'm delighted to be able to be here with you. I'm just going to share with you, of course, the medical education focus very briefly. Next slide. So you've already heard mention of competency-based education, and competency-based medical education is certainly where we are heading, where we're working on in the last 2 decades. We've been working towards a competency-based education model in medicine. And so this slide just includes several kind of examples of what we mean by that for those who are less familiar with CBME or competency-based education. It is a model of teaching and learning that focuses on the contemporary health needs of our society and our populations. It translates those needs, so it backwards designs the curriculum based on those needs and translate those into competencies or descriptions of the abilities that physicians must be able to meet patients' needs. So we answer the question, what does a physician need to know, do, or value in relation to a contemporary healthcare issue? And today we're talking about telehealth. So, and I'm going to give you an example of some competency work that we've done in this space. Competency-based education does view education as a continuum. So you don't actually, bad news is you're never really done, right? Learning is a continuous process. You may reach certain milestones in your progression and your developmental path, your journey, but that doesn't mean you're done by any means. So even our physicians who are out of practice for many decades, still have learning to do, still need to, or relearn in some cases, kind of practices that they know very, very, very well. And telehealth certainly one of those areas. The curriculum is also inclusive in a competency-based model, is inclusive of formal as well as informal teaching and learning, designed to teach and assess those competencies or outcomes. And it certainly is dynamic, as you can imagine. We're very interested in adaptive learners and in fostering adaptive learning and a growth mindset when it comes to teaching and learning. Next slide, please. So that was a very high-level, brief intro into competency-based education. And just to say, we do a number of things at the association to support competency-based education. I oversee a strategic initiative called a New and Emerging Areas competency-based series. And this slide just shows you kind of where we are in this new series. We released in 2019 our first set of competencies in new and emerging areas, and that was around quality improvement and patient safety. Just last week, so just a few days ago, we released our telehealth competencies. So I'm very excited to share that, even though we actually finished the competencies late 2020. It's why that date is there. But the formal report that's now available for free of charge in our store that you see pictured here just became available last week. We're also currently working on new competencies in diversity, equity, inclusion, as well as anti-racism. So those are underway now, and we anticipate finishing those up later in the year. And then these series will continue, and we will be reassessing these competencies every 2-3 years, depending on the set themselves, and refreshing them. So we don't intend for these to be put out there and ignored for many years, but to revisit them on a periodic basis. Next slide. So I want to give you a little bit more details about the telehealth competencies before we dive into the conversation. So as you, again, this audience knows very well that clinical education should always evolve with clinical care, and that as our delivery models change, particularly in virtual care delivery, so should our educational curricula and models change as well. And we also are very interested in fostering this co-creation of curriculum with not just students, attendees, and team members, but team members thought of much more inclusively or broadly than we ever have before. So certainly patients, but also in this space of telehealth, we have new healthcare team members, right? That we have not traditionally considered them part of the healthcare team. So we have various technologists and innovators out there who we should be reaching out to, connecting with, to co-create, develop, but also deliver curriculum. And there are a number of ways that care is different when we're working in a virtual environment. I, again, don't need to tell this audience that. There's just a few examples of how the practices are different, of course. And the competencies have been developed with these differences in mind. Okay, so next slide. This is just an overview of the scope. They kind of give you a little bit more detail about these competencies. They are intent. One thing I think is really important to, I won't go through all this, but one thing I do want to mention that's really important is that these are considered cross the continuum competencies. So these are not just for medical students. But they're also for residents and for faculty who've been out in practice and are required to teach and or assess these competencies for trainees. So we have them divided into 3 tiers. So when you look at the competencies and see the report, you'll notice that they're displayed in a developmental framework. So what do we expect of an entering resident into residency or graduate medical education, which is our first tier? What do we expect of a resident about to go into practice? And then our third tier, as I mentioned, was the faculty member who's responsible for teaching. These are not specialty specific, so they're quite broad, general for what do we expect of all physicians, regardless of specialty, to be able to do, know, and value in this space of telehealth. Next slide. We've been working on these for several years. This slide is just our journey over the past year. Where we have been, and we have followed, as we have with our other, with all the competencies of the series, we follow a very systematic and iterative process, very inclusive process. We have sent out for reaction to many hundreds of stakeholders. Some of you probably are on this call right now. Thank you if you gave us feedback. And over the course of about a year, really developed these competencies with through iterative versions. We followed a modified Delphi approach to do this. And again, very excited to tell you that they're just newly released. The next slide will show the 6 domains of competencies. So we have actually 20 total competencies, and they fall within these 6 buckets, if you will. We call them domains, but they're just kind of categories. I won't name all of these, but you're probably not surprised to see that we're very interested in and find, are focused on patient safety. So that is the first domain, if you will. Access and equity in telehealth, is also critically important. So we have a whole domain of competencies related to access and equity. Certainly communication is critical and quite different from in-person communication. There are several competencies on ethical practices and legal requirements, as well as the technologies, and then collecting data, including conducting a physical exam in a virtual way. Next slide. So as I finish up, I just want to, again, give another plug for this new report, which includes those competencies, and then, which you can find on that website. And then on the next slide is to ask for your help. And next slide. Thank you. This is my last slide, by the way. So here, I just want to make you aware, if you aren't already, we have 2 journals actually through the Association of American Medical Colleges. The first is MedEd Portal, and that is, we actually have an active call for resource publications that represent telehealth education from MedEd Portal. So we would love to see your submissions. If you have them, please submit. And of course, academic medicine as well as our second journal. And both of them, we are actively seeking your exemplary works and would love to hear from you. So do consider submitting. And if you have questions, on the next slide is my email, my personal email, as well as our telehealth inbox. So again, if you are doing interesting work in regards to teaching health professionals, not just doctors, but other health professionals as well, how to practice in these virtual environments, we would love to hear from you and help share your exemplary work. And so a couple ways to contact me there. Thank you so much.
And thank you, all of you. That was terrific. When I commented earlier that we have a lot of expertise on this panel, and they just showed that to us. And so now it's exciting to jump into the next portion of our session. I'm going to just throw out a couple already prepared discussion questions. And if we have time, eventually we'll get to some of those. Actually, I will make some time to get to some of the questions that are currently being listed in the Q&A portion of our platform, because I see some popping in already. But let's get started with the large question that's embedded in the written description for this session. So to anyone who wants to answer, or all three of you, from your perspective, what changes are needed to prepare the healthcare workforce for the future? And what opportunities might you see to make those changes?
Well, I'll jump in because Lisa and I talked about this earlier. Just the whole idea, moving to competency-based, which she's shared so beautifully, and the work that is the AAMC is doing. But that needs to be across all of our disciplines and looking at competencies, the growth mindset, the fact that we're never done learning because things change so rapidly, that we need to keep pace with that. And, that better connection, I would say, between pre-licensure education and the practice setting. I think, again, going back to the Titanic, we've had this nasty habit of kind of pre-licensure beginning practitioner education being somewhat divorced and separate from the clinical environment. And we do that at our own peril because things change so quickly. And a lot of the clinicians that have the knowledge that we need to impart to our students are embedded in those technology-rich areas in a way that faculty that are, more so on the education institution side just can't have. So you need that partnership and that real-time quality to education. So I'll start there and let our colleagues jump in.
Dr. Howley or Dr. Abdel Fattah, do you have anything to add?
I'll just kind of second, what Dr. Davidson mentioned, and that's this real need to kind of close that gap, right? Totally, completely agree with you. The more that we can integrate clinical practice with educational offerings, educational curricula and development, and connect that, the better we will be, and the more the closer and faster we'll kind of upskill our workforce actually to practice safe, equitable, accessible care.
I agree with both Lisa and Sandra that, we definitely needed competency-based teaching, but also we would like to have a curriculum. We would like to have a useful technology that really is put in use, that there is a purpose for it. I mean, we can train them, but they're not going to be using it. It's not going to help anybody. So we want to make sure that with interprofessional development and collaboration, that experience are put to use in technology and will help, for example, to reduce the clinical burden of the clinician and the burnout, while also improving the care rather than just have a curriculum and have technology and nobody is adopting it or nobody is using it or putting it to a good use. I think that's in the longer term, that's what's really gonna have to happen to sustain what we started with changing curriculum and revising those programs.
Fantastic. I suspect that if we had time, all three of you could talk more about that for the next couple of days, but we don't. So thank you for those responses. And let's get your thinking about another question. Has COVID affected your education or training work with healthcare students or providers? Or has it affected your thinking about your education and training work for healthcare students or providers? If so, how?
It was a challenge when we have to switch over immediately from in-person education to a remote online virtual education. All of a sudden it did happen, and we had a lot of a steep learning curve, but what we learned now we can use, and we would like to continue using that and build on it. So I think comes to mind would be online education, online simulation, and instead of only just seeing the patient inside the clinic, you can see the patient virtually. You can manage that patient, collaborate with the providers and the stakeholders using video telehealth or teleeducation. So I think online learning and developing more program that students can learn in an environment other than just the classroom will help a lot.
I would add to that. I think, you know, there was a move towards more online, more accessible, equitable access to healthcare education before COVID, but it really just accelerated it to the point where we're never going to go back to the way it was before. It may be, you know, pendulum swinging a little bit back more towards a little bit more face-to-face in ways that make sense for learning, and leveraging that face-to-face time in different ways that are value added. But we've proven to the laggards, I guess, and everybody else that you can do high quality distance or a blended online learning, that it's possible. And so it's just accelerated our plans to that. I think there's been some really great partnerships, again, based on the constraints of the COVID pandemic, around our students, you know, jumping in and working with the primary care clinics in our area to do health assessments via telehealth, which was never a clinical experience that we had available to us before. Virtual contact tracing that our nursing students got to be a part of on the front line, because we need the creative problem solving for those that were learning to supplement our ability to do contact tracing. So just a couple of examples that, you know, there are new partnerships that have formed that will see fostering further ideas and further creativity to the benefit of our patients and our students.
And I have to just build on that, on what has already been shared, that, you know, having a national perspective during this pandemic has been both a joy and a frustration, just personally at the same time. The frustration that I'm not there, you know, frontline and actively, you know, working and supporting our trainees and and developing curriculum in the healthcare settings. But I would say, you know, what has been so incredibly invigorating and exciting has been the opportunity to watch just how much innovation and it has taken place over this last year. And I would also add that I've also been really impressed, almost probably ties, you know, close second, is just how much collaboration and sharing has taken place. So, you know, I mean, in education, health professions education, we've always worked well together, but I have to say, I have seen kind of an unprecedented amount of reaching out across boundaries, right? Those boundaries, whether it's our institutions, the medical schools, the region, even those we might consider a competitor. You know, really, this pandemic, we've really seen those walls breaking down, which is really lovely to see, and people working better together to achieve, similar and important outcomes that they share in common. So really lots of innovative curricula, sharing of resources. Many of our vendors who do charge for their programming and their courses had suspended that, at least for a time being during COVID, to be able to provide greater access to some of their technologies when it comes to virtual learning. So really just seeing this broad community working together, better together, I would say, which has been just really wonderful to watch and be a part of, actually, and help facilitate.
Thank you all for that. And Dr. Howley, I feel like you've just begun answering the next question, which is what opportunities do you see for interprofessional learning? And in fact, I see a participant has submitted a question almost the same. How are you specifically addressing interprofessional education, a gap that still exists in clinical practice today?
I'll start with that one because, if you don't mind, for those who aren't familiar with the association, we are a member organization. The MD granting medical schools in the U.S., so 155 of them, as well as the 17 Canadian schools, are our members, as well as about 400 teaching hospitals, 80 plus specialty societies, a number of VA medical centers that support the academic mission teaching and learning. And so we have actually a pretty diverse, wonderfully diverse constituency. So the healthcare professionals who work within those organizations, of course, we consider constituents. And although we primarily focus on medical education, the physician development education, we're founding and very proud members of IPEC, which is the Interprofessional Education Collaborative, which I hope you're familiar with. If you're not, please check us out. It's IPEC.org, IPEcollaborative.org. And so we're very actively working across health professions and advancing competency-based education, but in other ways as well. Leadership development is another space that we're co-leading, right? Interprofessionally, leading interprofessional teams is we're very actively engaged in. And I do think COVID has kind of opened more doors than we have in the past to identify and provide these realize opportunities for interprofessional serving and learning, and learning through service. I think is such an important and valuable model, and that we don't often realize the full extent of. And I think there's over the past year there's been quite a lot of service learning, which has been wonderful. That is very interprofessional.
Dr.
I would just echo, I totally agree with Lisa. It's just opened a lot of new opportunities and a willingness, I will say, to entertain ideas and collaborations that we haven't seen in the past.
I agree with both of you guys, and for the College of Pharmacy to try to train the students and get them closer to the providers, we were able to set up this year telehealth and digital transformation call center in Roanoke with Brilliant, one of the largest healthcare systems. And the purpose of that is to have that center staffed by pharmacists, interns, and have rotation for both pharmacy students, medical students, informatics students, to be able to help support any effort and any initiative for providing telehealth, remote patient monitoring, chronic disease management. So that's part of what we have been doing, just trying to come closer to the user, which is the provider, and as a patient who are utilizing our services, because we feel that will help the profession. And as I mentioned earlier, a lot of physician and provider burnout and problem with the clinical flow could be solved with some of those technology you are using, and also some of the collaborations. So that's what we are really hoping to, as a part of our effort to encourage the interprofessional collaboration is to share what we have, whether little resources with some students to do the help or some technology platforms and devices we use. So all these together need to be put for the benefit of the provider and the patient. And while we're doing that, it will encourage and foster collaboration between us as professionals.
Thank you all for that. Earlier this morning, we've already been part of some conversation about the need for providers to continuously learn about emerging telehealth technologies and issues. So that directly relates to the next question, which is what strategies can be used or might you already use to motivate continual learning about telehealth among healthcare workers and practices?
I might just share an example of, so again, continuing professional education, I think comes in different shapes and sizes. And I know that, there's things like micro credentials, they're talking about macro credentials, which are kind of more purpose driven, stackable towards a master's degree, those kinds of things. So we're actually looking at creating a suite of ongoing educational opportunities for providers that is really relevant and timely and come in different shapes and sizes. Do you want to do a deep dive into one area, which would be a 4-course graduate certificate? Are you looking at a series of micro credentials across a number of different areas or competencies related to telehealth or technology? So really the modularization and customizability to our practicing professionals who want to stay up to date and in these emerging areas is one of the strategies that we're using.
Yeah, I think we have recently developed a fellowship program in digital health transformation and remote patient monitoring. So we're going to be accepting students for a fellowship program focused mainly on how to develop and disseminate the use of those technology with that fellowship program. I'm not really sure how many pharmacy schools already have that, but I think we started ours. We started in July the 1st to have our first fellow for that particular program.
And I would add, of course, I'm biased. I think education is the key to everything. But the question is, how do you motivate change, right? Or, which is, of course, at the heart of education, right? Of learning. It's how do you make it stick or sticky? I would say, at least with physicians, so my experience in medical education is that it absolutely has to be relevant and it has to be personal, or it should, ideally it's personal. Meaning that if you can engage them in actually developing and their own kind of personal individual plan for learning and improvement, all the better. So if there is, their own practice data can be shared to understand, how their practice might be changed or affected or impacted if they shift to virtual care. Of course, when we talk about telehealth, there's so many different. We're not talking about one thing, right? It's so but generally speaking, I would say, when we talk about educating physicians, it has to be very relevant and engaging, and I hope that those who are working to develop the curriculum include the learners, right? Whether those learners are students or whether they're physicians who've been out in practice for a number of years. I mean, learners need to be engaged and to understand the why behind their need to change and learn differently or practice differently, so they could then practice differently. So close connection, engagement, understanding the needs of that individual learner is key.
So speaking of learning and ways to learn, we talked about COVID earlier, where we saw a big shift of learning to online learning. Dr. Davidson and Dr. Abdel Fattah, you were mentioning some certificate or degree programs. So here's the question. As healthcare students and professionals participate in distance-based learning, from your perspective, what about their distance-based learning experience might be transferable to their provision of distance-based care? Likewise for distance-based educators or trainers.
Well, I think I had one item on one of the slides that I flew through is, in health professions education, technology is both a what and a how, right? And it can be. And so, having the opportunity to learn in an online way gives you ideas about how you might translate that into your clinical practice, right? So, as a student, what it feels like when you're not having a good conversation with a learner or an instructor of a course. And you might think, that's probably a practice that I don't want to do when I'm actively talking to a patient in a telehealth session. So there are transferable skills, absolutely. I think something that Shanley said, having opportunity as learners to use live systems or sandbox versions of live systems, so that we're not, it's not just an exercise in education, but training practitioners on the systems that are most like what they're going to use, I think is one of those things that we can really do. So that's an example of those partnerships where, in Alberta, up in Canada, Epic is actually implementing their system across our entire provincial health system, which is the largest implementation that they've had. And so there's been this great partnership that we, as educator of nurses, that are going to be, 80% employed in that health region, that our students have access to be able to learn and practice using Epic as students, even before they get to the clinical setting. So I think that's really important. The fidelity of the stuff that we practice on needs to match the clinical reality.
I agree. And the biggest thing, problem was technology. We got thousands of technology came up overnight. The best way to use the technology is to find the most useful technology, the easiest to use technology, because you're not going to be using 10, 12 technology in the day for one patient. You're going to have to, at the end of the day, figure out which technology you're going to use. And that one is going to have to be the most easier to use, the most adaptable or extendable one, and also it is the one that will do the job. And I think that's going to be a huge part of teaching telehealth and technology. Yeah, I mean, you can't use all the technology. You have to concentrate on the technology that is useful to you, that's appropriate to your case, and at the same time is not going to be, cost prohibitive as well.
Thank you for those responses. We do have just about a minute and a half left to address some questions that have come in through the chat. And Dr. Abdel Fattah, since you're speaking, there's one that's been sitting here voted up twice for you specifically. Very interesting to consider pharmacists to offer these services. Do you use IP or ambulatory pharmacists? Did you have to hire additional pharmacists to be able to cover the delivery of these services?
Yeah, great question. Thank you so much. I think the whole idea when we say pharmacist, because our impression of a pharmacist, he is sitting in a drugstore around the corner, 5 miles away from where you live as a patient. And the job for that pharmacist is just filling prescriptions. And that's the most common one. Of course, the pharmacy is the most trusted. It's more available everywhere. So in our program, we have a combination. We use ambulatory care pharmacists. And I will tell you why we don't put a pharmacist in every clinic, which we would love to, because it is cost prohibitive. One of the issues with a pharmacist, we are not a provider according to the CMS, which means if I provide diabetes education, which I do all the time, or lifestyle modification to a patient on hypertension, I don't get paid. Who gets paid is the provider, is the doctor. And the problem is, well, the doctor can bill for their service and I'm doing the work, which is great, but the doctor only get paid $50 per visit. How are we going to ask the doctor of the clinic to pay a pharmacist from that $50? Because the pharmacist's salary is expensive as well. So that's one of the issues. We could not really get a pharmacist to be in every clinic in person, but with virtually, yeah, we have the patient scheduled as the clinic, and they call the pharmacist for the 20-30 minutes, and the pharmacist can do that. So we have that pharmacist virtually available remotely, and they can cater to many clinics, not just only one clinic. They just have that appointment and do that. So that's as part of the technology and the remote virtual ability to embed a pharmacist in the clinic to allow a pharmacist to cater for more than one clinic. But also at the same time, my project goal and the pharmacy focus is 90% of my pharmacy graduates, so 90% of the students graduate from my college, they go to retail pharmacy. So they work on that pharmacy around the corner, sitting behind the counter, and they count in pills. This is not what they do all the time, but this is what they're supposed to. So they have a lot of time, they can do clinical work. And this is what we say, okay, well, the next phase is gonna be those pharmacists in the pharmacy, in the community, they need to be the hub of the care virtually. So I hope I answered your questions.
And you probably could continue answering it again for another couple of days. Unfortunately, we are completely out of time. In fact, we've run just a minute over. And Dr. Howley, there is a question here, though, that I suspect you can answer in 5 seconds that a couple people want to know. Are the AAMC articles open access?
Yes.
Perfect. Okay. Sorry?
Trying to save you some time.
So thanks everyone for joining. Thank you panelists for sharing your expertise, or some of it anyway. Everyone, please don't forget to provide session feedback using the event platform. Maybe I'll see you in a few minutes in the virtual exhibit hall over the lunch break. I do hope to see you over the lunch and keynote session at 1. Hope everyone has a great remainder of your day. Bye.